Assalamu alaikum everyone. Welcome to you all to this session today. Today we will talk about chest X-ray for GP, and I think my voice is clear. If it is not, you can comment here. If you can hear properly, please write in the chat box. Okay, let's begin. Okay, thank you. So today we will talk about chest X-ray for GP. Actually, in this session, I will talk in the perspective of a GP's GP. That means general practitioner or family medicine physician. So we know that chest X-ray is a very important part of our clinical practice. And as a GP, you have to have a very sound knowledge about the chest X-ray. And in the periphery, especially when you are doing GP in the periphery, and then you will find that there is no one to interpret the X-ray for you, and there is no one to report the chest X-ray. So you have to have a very good knowledge and a sound knowledge also to for the chest X-ray. So in this session, I will try to make to clear some points about the chest X-ray. I think it will be helpful for you. So first thing is that what are the advantages of chest X-ray in practical view? Number one, chest X-ray is widely available, and you know that nowadays chest X-ray is very available, even in the upozilla level. It's also very available, and sometimes we see that in the opposite level where digital X-ray is also available. So it is widely available and also reliable. Why it is reliable? Because in the periphery, in the third world country like us, you know that the other tests like the blood test are not reliable actually in the all labs, and it varies very labs to labs. So, but in chest X-ray and or ECG like this, it's very reliable, and you will find directly to the patient's chest with the help of the X-ray. So it is very reliable and also very cheaper actually, and very simple technique. It has no any complicated techniques like the CT scan or MRI, and very cheaper, and very lower socioeconomic persons can bear this. And the another point is very low radiation in compared to CT scan. You know it. And lastly, the patient complaints. So when the patient has any chest complaint like like cough, chest tightness, or any pain in the chest, if you advise him or her that you should do a X-ray, I think they understand that it's necessary for him or her to do a chest X-ray. So it is very patient complaints actually. Okay, so starting the reading a X-ray, actually we have to find something whether this chest X-ray is has done in right way or not. Like firstly, you have to look for the X-ray whether it is in inspiration phase or in the expiration phase. It is very important. Uh, as we know that in our country, like in other also in the third world country, all the technicians are not good enough and they have no proper technique or proper training to how to do a proper X-ray actually. For this reason, they don't know so whether the X-ray should be taken which time. And invariably, I found that in my center where I practice in the rural area, that the technique sometimes patient come with the X-ray in the expiration phase. And when I told the patient that when you were in the X-ray room, did the technician tell you that please take a deep breath and hold it? In the maximum patient and the most of the patient tell me that no, I had no any direction or in like this. So most of the technician in our country and also in the other countries like us, the most of the technician they don't have the proper knowledge to how to do a good X-ray. So you have to look for this X-ray whether it is in inspiration phase that should be done actually, or in the expiration phase. Suppose in this X-ray, look at this, it is in the inspiration phase. So it looks very well and very good enough. But look at here, in the same person in the test, in the X-ray, in the expiration phase, then it's very, it's looking just, this patient may have some cardiomegaly and also may have lower zone consolidation like this. But this patient has no any kind of this kind of diseases. Just the X-ray was taken in the expiration phase. For this reason, this X-ray looks like this. So of course, it's very important, to take the X-ray in the inspiration phase. Look at here, the same, another patient, it is in the inspiration phase, and the same patient, it is in the expiration phase. So it is very important to know about this. The second thing is that you have to look very carefully in this part. In this part, this is the spinous process of the vertebra, and this is the medial end of the clavicle. Always there should be, this spinous process should be equally distanced between the two clavicles. So it should be equal. If it is not equal, so you should think in your mind that this patient may be in the rotation phase, or rotation, and in the rotation phase actually. Like in this X-ray, look at here, this is the spinous process here, and this is the medial end of the clavicle, one, and another is here. You can see it is not in the equal distance between them. It is more very close in this clavicle in the right side. So this patient in the right rotated phase. That's why this her or his actually the heart becomes very large, and you can comment about the, without knowing this thing, that it may be a cardiomegaly, but this patient has not the cardiomegaly actually. Actually, for this rotation, is the heart size is enlarged. So always look for these two things, and it will help you a lot. So suppose in this patient came to you with this X-ray, and you thought that this patient has cardiomegaly, please go to the cardiologist, etc., etc., blah blah blah. But it is not necessary for this patient, because this X-ray was not properly done. Okay, now look for the some points of the X-ray, that the anatomical landmark here, that this is the trachea, this is the black portion, is the trachea, this is the spinous process, I told you, this is the clavicle, and this is the carina of the trachea, the last part, the bifurcation part, and this is the right hilum and pulmonary artery. This part is the pulmonary artery, you know it, and this is the hilum area, left sided, and also the pulmonary artery. And this is the left ventricular area, that is the right ventricular area in here, and this is the right atrial area in here. Okay, so always mind that it is not the right ventricular area, it is right atrial area, and right ventricle is between the right ventricle and right atrial area. Okay, so this is the diaphragm, and this is the costophrenic angle, of course, and of course this is the breast shadow. Okay, so it is the X-ray of a female. So when we look for a X-ray, we will go in the chronologically, so that we don't miss any changes in the X-ray or any pathology. Suppose this is the one formula that you can follow when you will interpret a X-ray, like A, B, C, D, E. In A means airway, you will look for the airway. Then the bony change, whether there is any fracture present or not, or any deformity present or not. Then the C for the cardiac shadow and cavity relation. So we have to look for the cardiac enlargement or not, or any valvular change or not, or any cavity relation in the lungs. Then D for the deformity, and E for the extras, like is there any presence of nasogastric tube in situ, or pacemaker, or ECG electrodes, or any peripherally inserted central catheter, or any foreign body, or any ET tube. Okay, so if you go in this chronologically or systematically, then you wouldn't miss any pathology. So this is the a very normal chest X-ray. and we will go in the chronologically as this in this formula. Okay, so now let's play. So our first case is that a 20-year-old boy with nocturnal cough, shortness of breath, and wheeze. And another thing is that you have to always try to correlate the X-ray with the clinical findings of the patient. Suppose you are in the GP center and the patient has come to you, and you have just advised a X-ray. But firstly, you have to take some history of the patient. You have to do some clinical examination of the patient. Then in your mind, you should set up a provisional diagnosis for this patient. And then you should advise an X-ray for this patient. So without knowing the clinical knowledge or clinical history, it is very likely to miss the diagnosis. So always, I am telling you in the repeatedly, always try to get the history and examination of the patient. If you have not the patient in your contact, then when you will get the X-ray, you can make a just a story of this patient. Like if you get this any X-ray, then you are getting some findings, then try to correlate with the other findings of the patient. Or if this patient has this, maybe this patient has this, or his may or may not has this problem like this. But always try to correlate with the clinical findings and the history. So now our case, first case is a 20 years old boy with nocturnal cough, shortness of breath, and wheeze. So from this history, we will, is a young boy, just patient has nocturnal cough, sometimes shortness of breath and wheeze. So I think it's very suspicious that this patient may have bronchial asthma. And look at the X-ray here, and we are seeing that this is a very normal X-ray. So in a normal X-ray, this patient has shortness of breath and wheeze. This is the most likely diagnosis of bronchial asthma. So in bronchial asthma, chest X-ray is normal. So our second case, a 50-year-old heavy smoker with shortness of breath, weight loss, and peripheral edema. Okay, so from the history, we are seeing that this is a very old person. There is a 55-year-old heavy smoker. That means he is a long-term smoker with a shortness of breath, and he has weight loss and peripheral edema. So we have some differential diagnosis for this patient. So maybe it is a case of heart failure, or maybe a case of COPD, or it is maybe a case of pulmonary hypertension like this. So when we will examine this patient or taking some history from this patient, we have to keep some differential diagnosis for every cases. So now I have, suppose we have ordered this X-ray for this patient, and patient has done this X-ray and it has come to you. So in this X-ray, we can find that in this X-ray, it is the translucency of the both lungs is increased, obviously, and the heart shadow is just more likely tubular shape. And you will find that the vascular prominence is also here, and this is the dome of the diaphragm, just is more flattened actually. So in this change with the clinical history, we can find this is the case of heart. What should be the case? What should be the diagnosis? Can you tell anyone? You can write in the chat box or tell directly.
COPD.
COPD. Very good. So why this patient has peripheral edema?
Right heart failure.
Good. Very good. So in COPD patient, it is very more likely this patient may have cor pulmonary. So what is cor pulmonary? Cor pulmonary means right ventricular hypertrophy or right ventricular failure due to lung cause. Most probably, most commonly the COPD. And this patient has weight loss. That means we know that in COPD is a very catabolic state, and there may be some muscle loss and consequently the weight loss. Okay, very good, doctor. So our next case is a 25-year-old man with high-grade fever, cough, rusty color sputum for 3 to 4 days. So very straightforward case. A young man with very high grade fever, cough, rusty color sputum for 3 to 4 days. So for this clinical, with this clinical history, what's in your mind? Can you tell me or write in the comment section? Anyone?
Abscess.
Abscess. In abscess, we don't expect the rusty color sputum. Actually, we expect some
Pneumococcal pneumonia.
good, very good.
Bronchitis.
No, in bronchiectasis, we don't expect rusty color sputum. In the when there will be rusty color sputum, it is very pathognomic for the new community acquired pneumonia caused by Streptococcus pneumoniae. Okay, so from the history, suppose in this case, we will expect some diagnosis. If you don't expect any diagnosis, then you wouldn't diagnose this patient. So expectation is very important. And as you have told that when another person has written in abscess. In case of abscess, yes, there may be presentation of fever, cough, but rusty color sputum is not present. We expect a very big amount of sputum, that is very foul smelling sputum like this. So in rusty color sputum is very pathognomic for Streptococcus pneumoniae. Okay, so we have ordered the X-ray and we are just expecting of the findings of the consolidation. And fortunately, of course, it is very unfortunate for the patient, but fortunate for our doctor, that is for the diagnosis, for making a diagnosis. So we are seeing that in the X-ray, that is the very homogeneous, partly homogeneous and partly inhomogeneous opacity in the right lung field. And this is called the consolidation. As the trachea is in the central position, so of course this is a consolidation. If it is a lung lesion like any mass lesion, then forming a collapse may be a good possibility. But from the history, and as the trachea in the central position, so it's definitely it's a consolidation. So our diagnosis is community acquired pneumonia due to Streptococcus pneumoniae. So if you can diagnose this patient clinically with the help of the X-ray, then treatment is very easy. And most of the time we fail to diagnose this patient, and that's why we fail to cure the patient. Okay. So our next case is a 30-year-old woman with high-grade fever, cough, liver impairment, and hyponatremia. So suppose this young patient has come to you with high-grade fever, cough, just like the previous case, and he has some liver impairment, and she has hyponatremia. And you have ordered an X-ray, and she has come with the X-ray. Okay, so look at the case here that the patient has respiratory problem, liver problem, and also electrolyte imbalance. And in the X-ray, we are seeing that this patient has bilateral consolidation. This is the partly homogeneous and partly inhomogeneous opacity that present in bilaterally. So what is the combined diagnosis? Can you tell anyone, doctor?
Legionella pneumonia.
Very good, very good, excellent, excellent. So look at here, just from the history and some investigation, suppose this patient liver impairment and hyponatremia with the bilateral involvement of the chest, it's very most likely caused by the Legionella pneumonia. So the moral of the talk is that in here, that from the X-ray and with some history and also some lab investigation, we can suspect that organism. So it is very important, because if you can't imagine the organism, and if you don't know about the organism, you can't treat the patient properly. So you have to give the proper treatment for this patient. So our next case is here. So 25-year-old man with high grade fever, cough, liver impairment, just like the before case. And additionally, this patient has erythema multiforme and anemia. Okay, so the previous patient had hyponatremia, but this patient has erythema multiforme. That means when this patient has come to you, uh, if you don't do general examination, then you would miss this skin change. So it's very important to do the proper examination of the patient, not for the not only the respiratory system, but you have to look for the other system, and also very importantly general examination, because in general examination we can find the anemia of the patient, and also when we will see in the whole body skin, then we will find the erythema multiforme. Okay, so we have ordered a X-ray, and we are seeing this kind of changes in the X-ray. That is the bilateral involvement, like this other one, the previous one, also bilateral consolidation. So what's the unifying diagnosis? Can you tell?
Mycoplasma.
Good, very good. Yes, very good. In the comment section, Dr. Ataharuddin, he has written mycoplasma pneumonia. Very good, doctor. Very good. So, so what is the final word or the moral of the topic? That is we have to take some history and to do some physical examination, of course, for the respiratory system, and also for the general examination and other examination also. As the patient has liver impairment, so this patient may have any clue about the history and also in the clinical examination. Okay, so our diagnosis is mycoplasma pneumonia. So we can diagnose and we can just suspect the organism from the X-ray, and just it's very easy actually. If you know about all of these things, then I think you can diagnose this patient. So our diagnosis is mycoplasma pneumonia. Very good, very good. So our next case is sign symptoms of pneumonia with bulging fissure sign. Okay, so you can see in the X-ray that this patient has just like consolidation like feature as the trachea in the central position, so it's not the collapse or fibrosis. But this patient, in this lesion, it has bulging fissure sign. That means this lesion is just bulging in the downwardly. So what could be here? If you find this kind of X-ray in your chamber, so what will be in your mind? Can anyone tell? Okay, no problem. So when we will find this kind of X-ray, so we have to take some history from the patient, whether this patient is alcoholic or not, or patient has any immunosuppressive conditions like diabetes mellitus, or any patient taking any immunosuppressive drugs like this. So if this history is positive, then in this bulging fissure sign is very indicative of Klebsiella pneumoniae. Okay, so the moral of the topic is that we can suspect the organism from the chest X-ray very easily. So just you have to know, and you have to correlate to the clinical history. Okay, so after doing all this kind of pneumonia, our our thing is I think just like this, just like a twisting. So if you are foreigner, if you are international, not Bangladeshi, I think you don't know about this food. It's a very tasty food in our country, and very popular food, and very sweet, and I think it's very delicious. What do you think, doctor from Bangladesh? Anyone can share about the
Yes, it's very delicious.
is very delicious, of course. So after seeing all of this X-ray of the different kind of pneumonia, I think in your mind, these are actually twisting in your mind what what we are doing. Okay, so we have to make it this like this, just straight, and we have to eat in this way to make it straight. When you will practice this kind of X-ray repeatedly in your clinical practice, then you will find that it's very easy to diagnose. Just you have to practice, and you have to know something. You have to just study well. Okay, so come to the next question. A 40-year-old female with cough and with sputum occasionally with mixed blood. So patient has cough with sputum occasionally with mixed blood, coarse crackles on the chest exam. So when you did the examination physically, then you you found that the chest X-ray exam, that is the crackles. She had history of childhood TB and multiple pneumonia. So so in this X-ray, we find that there are some lesions bilaterally present, and also I will not tell right now. Can anyone tell or write in the comment section?
Bronchiectasis.
Exactly. Very good. Very good. So look at the history of the patient. This patient has cup with sputum production with occasionally mixed with blood and coarse crackles. Very important for the bronchiectasis. So when we will get the coarse crackles, the bronchiectasis, lung abscess, or pneumonia in resolution phase, all are very important differentials. If it is fine crackles, then heart failure or IPF should be the differential diagnosis. As this patient, look here, this patient has childhood tuberculosis and multiple pneumonia. So previous tuberculosis and multiple chest infection is a very good risk factors for becoming the bronchiectasis. And there are also other some risk factors of bronchiectasis, like if this patient has allergy bronchopulmonary aspergillosis, or any bronchial tumor that obstruct the bronchioles, or any mucus plugs that obstruct the any bronchioles, that may contribute to the forming the bronchiectasis. So in this case, this patient has childhood tuberculosis and multiple pneumonia. As this patient has very sputum production with occasionally blood and coarse crackles, so it's very suspicious of bronchiectasis. And in the chest X-ray, you can see that there are some bronchiectic chains in both lung field. These are the bronchiectic chains. And in bronchiectasis, actually, chest X-ray is not conclusive, and just it will give you some clue. This patient may have some bronchiectasis. So, as a GP, you have to just suspect this may be a case of bronchiectasis. So you can order a HRCT, or you can refer this patient to the higher center. Okay, so in the higher center, we do the HRCT. So HRCT is a very good investigation for bronchiectasis diagnosis. So you can see in this CT scan of the chest, this is the bronchiectic chains, and this is called signet ring. In signet ring, just like a ring which we wear in the fingers, and you can say this is the dilated bronchiole. This black part, and this white part is the blood vessels, and this forms this kind of signet ring. And also we can find some traction bronchiectasis. That means a series of dilated bronchial wall may cause this traction bronchiectasis. Okay, so and importantly, always keep in your mind that the bronchiectic change is most likely in the medially of the chest. If it is in the peripheral part, then the IPF or DPLD could be the differential diagnosis. Okay, so come to the next question. A 50-year-old man with chronic cough, low-grade fever, and weight loss. Very straightforward. Chronic cough, low-grade fever, and weight loss. So our X-ray has done, and you can see here that there is some partly homogeneous and inhomogeneous lesions in the upper part of the right lung. So as this patient has this kind of clinical features, so I think it's a most likely or most probable diagnosis is pulmonary tuberculosis. So, so same kind of X-ray, if this patient has high grade fever and very short duration, then we would think about the consolidation. But as this patient has chronic cough, low grade fever, and weight loss, and in X-ray, in the upper part of the right lung is involved, as in the in tuberculosis is the very choosable part of the lung, that is the upper part of the lung involvement. So it's a clean cut case of pulmonary tuberculosis. Okay, so this is our pulmonary tuberculosis, and it is very common disease in our subcontinent. Now the next question is here. A 45-year-old female with shortness of breath and right-sided chest heaviness, and You have ordered a X-ray, and with these findings, what is the diagnosis, doctor?
Pleural effusion.
Definitely,
Pleural effusion bhai.
definitely, it's a pleural effusion. But pleural effusion is not the definitive diagnosis. We have to look for the cause of this pleural effusion. So again, we have to take the history from the patient. Like if this patient has very high grade fever recently, then the pneumonia effusion may be the possibility. If this patient has low grade fever, weight loss, then tuberculosis may be a possibility. Or if this patient is suppose this patient age is more than like 60 years or 65 years, then the carcinoma is also a possibility. Or if this patient has uh, uh, any joint pain like this, or any skin changes, or any pulmonary or any subcutaneous nodule, then the rheumatological disease would be a differential. So we have to take a very good history from the patient, and always without proper history you can't diagnose this patient. So it's a very common problem, and invariably we find this kind of X-ray in our chamber. And most of our doctor get become anxious with when this they find this kind of X-ray, the what he or she will do with this X-ray. So clinical history is very important. With the clinical history you can diagnose this patient very easily. Okay, so our next question is that a 55-year-old man with progressive shortness of breath and clubbing. So very straightforward case. He has progressive shortness of breath and clubbing. In the X-ray, what is your diagnosis and findings? Can you tell anyone?
Interstitial lung disease.
Good, very good. So very good, doctor. So in the X-ray, we find that there is some reticulonodular shadow in the both lung field, more on the peripherally, isn't it? So it's a very good suspicion that this patient may have interstitial lung disease or DPLD. So what is the importance of this X-ray for a GP? Because if we find in our GP center this kind of X-ray, so it's important for him to refer the patient to the higher center. So it's the job for the GP, okay, to refer the patient. Because if you don't know about the X-ray of a DPLE or interstitial lung disease, so you would miss the patient, and you would just misdiagnose this patient, and you will do harm for this patient. So with you have to have proper knowledge, and you have to know about the X-ray changes of different diseases for you and as well as for this patient. So it's maybe a very good possibility of a have interstitial lung disease. So we have to do HRCTs for this patient. So when we will do HRCT of this patient, then we will find that this kind of reticulonodular shadow, that is the honeycombing in the periphery of the zone of the lung. And I told you that bronchiectasis always most likely they involve the medial portion of the heart, medial portion of the lungs, and the IPF or DPLD that involves the peripheral portion of the heart, and it becomes honeycombing of the not heart, actually chest. Okay, so this is the changes in HRCT in the for the IPF or interstitial lung disease. Okay, so I think we are in the last part. So a patient with bilateral hilar lymphadenopathy, very straightforward case. So this patient has bilateral hilar lymphadenopathy. As you can see in the X-ray, there are some lobulated lesions in the hilar region bilaterally. So when we will get this kind of X-ray in our practice, then we have some good differential for this patient. The first differential should be, what should be?
Sarcoidosis.
Sarcoidosis. Very good, very good. So when we will get bilateral hilar lymphadenopathy, sarcoidosis should be our most priority. And of course, lymphoma or tuberculosis or histoplasmosis or berylliosis, all are the other possibilities. But at first, you have to exclude the sarcoidosis is present or not. For diagnosing the sarcoidosis, you have to take some history from this patient, whether this patient has fever or any skin lesion or any lymphadenopathy peripherally. So you have to look all for this. And for the other differential diagnosis, you have to take other kind of history. So always I'm telling that history is very important. Now, a 60-year-old female with chronic cough, weight loss, clubbing, and hemoptysis. Again, the 60-year-old female with chronic cough, weight loss, clubbing, and hemoptysis. And we have ordered a X-ray, and you can find that there is a lesion in the left side of the left lung. So it's a very lobulated lung lesions. So as from the history, we would expect this may be a case of bronchial carcinoma, because this is the aged people, aged man, aged woman with she has chronic cough and also weight loss, and importantly, this patient has hemoptysis with clubbing. All the findings, all the points that suggest also bronchial carcinoma. So we have to exclude the carcinoma of this patient. So we have to do other tests like CT scan of the chest, and we can do FNAC of the chest, and we can do bronchoscopy with transbronchial biopsy of the from the lesions. So for the GP, what is the important lesson for the GP? So if you are GP, when you will get this kind of X-ray, you have to refer this patient to the higher center. So if you tell that I'm a GP, so it's not necessary for me. No, when you can get this kind of X-ray in your GP center, when you will get this kind of X-ray with the clinical suspicion, always you have to refer this patient to the higher center. It will be good for you, as well as it will be good for the patient for early diagnosis. And and also, you can, as a GP, you can suspect different kinds of bronchial carcinoma clinically. Like if this patient has clubbing or hypertrophic pulmonary osteoarthropathy, then squamous cell carcinoma may be a good possibility. If this patient has paraneoplastic syndrome, or this patient has other neurological symptom with this X-ray, then small cell lung carcinoma is good possibility. If this patient has gynecomastia, then adenocarcinoma is good possibility. I'm not telling that you have to diagnose this patient. Just you have to know about the disease so that you can refer this patient to the appropriate center. So our game has not been finished yet. So this patient has 50-year-old man with acute shortness of breath and tachycardia and bilateral basal crepitations. So this patient has shortness of breath. It is very acute, very recent onset, and tachycardia and bilateral basal crepitation. In this X-ray, what is the findings? Can you tell anyone? What are the findings here?
Consolidation in both lungs middle zone.
Okay, this is a good possibility. Yes, this is a good possibility, but from the history, we wouldn't expect
Carl
consolidation.
is
Yes, good, very good, very good. So this patient has homogeneous opacity bilaterally in the middle portion of the lungs, but it's called battering appearance. So in battering appearance, and also you have to look for any curly B line present or not. As in this picture, you can see some horizontal line that is called curly B line. So in this curly B line with battering sign, with the history, as this patient has no fever. If this patient has very recent onset high grade fever, then consolidation would be a good possibility. But as this patient has no fever, just acute onset of shortness of breath and bilateral, and importantly, bilateral basal crepitations. So bilateral basal crepitations when in acute shortness of breath, acute LVF or acute left ventricular failure is the diagnosis. And always we have to exclude and we have to treat this patient as a case of acute left ventricular failure, because it's a life-threatening condition. If you can't diagnose this patient and treat this patient, the patient may die. So it's very important for a GP when you will get this kind of patient in your chamber or GP center. So if you can't diagnose this patient, then patient may die. So it will be very harmful for you. And you know that in our country or in this subcontinent, when patient dies, the patient party, what can they do? So you have to acquire good knowledge also. So our game has been finished, I think. If you have any question or if you have any compliments about our free session, you can tell. Okay.
In bronchiectasis, signet ring. Can you please explain once more?
Okay. In case of bronchiectasis, if we open this, okay. In case of bronchiectasis, in chest X-ray, actually, in from the chest X-ray, the findings are not very clear. So we have to do another HRCT for this patient. In HRCT, you can see that there are some. This is called signet ring, as you can see here, just like our finger ring. And this black portion, there is the wide black portion, is the bronchial wall, dilated bronchial wall. And in the beside of the dilated bronchial wall, this white thing is the blood vessels. So combined of these two things, just like it forms just like a ring. This is called signet ring. This is very pathognomic for bronchiectasis. Okay, clear, doctor?
Okay, thank you. And the black portion is thickened bronchial wall, and the white portion around the neck.
Dilated bronchial wall. In
Uh,
bronchiectasis, there should be abnormal dilatation of the bronchial wall.
Direct bronchial wall, and the white portion
Is the blood
the
vessel.
blood vessel.
Okay.
Okay, thank you.
So
And in heart failure, the bat wing sign. Can you please explain?
okay, in heart failure, actually the heart is the pathological process is here. In heart failure, we know that there should be pulmonary edema. So when pulmonary edema forms, so there should be some consolidation like feature, but this consolidation like opacity would be from the heart to the periphery. So this lesion, look at very carefully. This lesion arises from here, and just like it goes in the periphery. So when it will go to the from the heart to the periphery, it will just look like a bat wing. Bat wing. Okay.
Okay,
So it is called bat wing sign. Okay. And also when you will get this kind of X-ray, then you will look for the periphery whether there is any curly B line or curly C, curly A line. Most importantly, curly B line. Okay. So I think today's session would be helpful for you, if I'm not wrong. Is it
okay,
helpful
thank
for you?
you. Yes, yes, very nice presentation.
Okay. So thank you so much.
Thank you
And
so much.
thank you so much for participating and your patient hearing. So I think if you are, it is beneficial for you, and after some time, or we would take some this kind of session regularly. Okay. So thank you so much, doctor. I'm ending this session. Thank you again.
Thank you.